Yes, in this section we will discuss about the molecular classification of CA breast, because the basic breast points you will know it, but this is of hot topic recent days. So what is the thing here under the molecular section is that we do molecular studies. Yes. So what is the type of biopsy required for studying the molecular basis of CA breast? It is the true biopsy. Just remember that's true. So we are studying receptor status. So that is the thing. It's called as the true. And then here we have the luminal A, luminal B type, and then basal, and then will be the HER2. Here the important trick is that it is the basal type. So basal, it is the all negative. Okay, so basal type, it is the all negative. So all negative means it is going to be BRCA1. Okay, and then it's going to be luminal B. B for basal is going to be negative, and then luminal B is going to be for positive for all the receptor status like estrogen receptor, progesterone receptor, and HER2 receptor, and it is going to be BRCA2 here. Okay, and then here luminal A, it is the most common. It is present in all, so it's called the most common. There is a trick here, and it's going to be PR positive, PR positive, and HER2 negative. So only HER2 is negative here, and another thing is then what is the difference between this and this? HER2 positive. So it's going to be HER2 only positive and others are negative. So these two are the extreme variants. Like here we have the HER2 is going to be negative and HER2 only is going to be positive, and it's going to be luminal A and HER2. But luminal B is going to be BRCA2. It's going to be all positive, and basal is going to be all negative. It's going to be BRCA1. That is the similarity between these two. Okay, so what is the other point? It is the most common point. It's the best prognosis, and this is the poor prognosis. Okay, so then you have to see about the imaging about the various receptor thing, luminal A, luminal B. So what is the trick here is that anything which is black, it's going to be positive. So here we have two blacks and two blacks for ER, TR. Okay, so that's going to be for the luminal A, and it's going to be for everything is going to be relatively black. It's going to be triple positive, maybe the luminal B. So it's a BRCA HER2. It's going to be HER2. It's going to be only one positive, and here it's going to be triple negative. So this is the triple negative form, and the basal like is a triple negative form, and luminal B is the triple positive form. Don't confuse between these two. And then there is a scoring is called as the Aldred scoring. So what does Aldred scoring say? So Aldred scoring is depending upon the ER and PR status. So we calculate two scores from it. So by the receptor status, there is the proportion score and intensity score. So this the sum of these two. Okay, so that is the Aldred scoring. So why is it important? So Aldred scoring is important to get the benefit of tamoxifen therapy. So ultimately we are studying this receptor status for the treatment only. So here it is going to be for the tamoxifen therapy. So here we have to get the total score. So it is a proportion score. It's going to be for 0, 1, 2, 3, 4, 5, and here it is going to be the intensity score is equal to 0, 1, 2, 3. Okay, so here you have to split from 1 to 0 to 100 percentage of the cells involved. Depending upon the percentage of cells involved, we will be calculating the score here. It's going to be 0 cells, and it's going to be less than 1 cells, and it's going to be less than 1 to 10 percentage of cells, and it's going to be 10 percentage less than, it's going to be less than 30 percentage, it's going to be 33. I'm just going to roughly saying it 33. So it's going to be less than 66 percentage, it's going to be 33 percentage, and it's going to be less than 100 percentage. So this is the classification for the proportion scoring. And for the intensity scoring, it is going to be intensity, right? So it's going to be negative, so it's going to be weak, it's going to be intermediate, and it's going to be severe or strong. So this is this thing. So by the sum of these two, we will be getting the Aldred scoring, and depending upon that, we will be determining the response of the tumor to the tamoxifen therapy. For so the Aldred score, what is that score? And the sum of these, it's going to be no effect, and it's going to be 1, 2 to 3, and 4 to 6. Just double it. Okay, so 4 double, it's going to be 8. It's going to be 7. So it's going to be no effect, it's going to be small chance, it's going to be 50% of chance, it's going to be 70% of chance for response to tamox. Okay, then we will see about the BRCA1 and BRCA2. Okay, so BRCA1 and BRCA2, so it's going to be 7, so 7 always 17Q. Okay, 7, just 17q, and it's going to be 2 here. So the next number is going to be 3, it's going to be 13q. It's only q here, it's not p. I saw a question playing in this part. And then it's going to be BRCA1. I already said that BRCA2 is going to be positive, so it's going to be ER positive, PR positive, whatever may be shit, it's going to be positive. And it's going to be 80% of the breast CA, and it's going to be 20% of the ovarian CA. But here it's going to be 60% of the breast CA, and 40% is going to be ovarian CA, and it's going to be the worst type. Already said now it's going to be the triple negative, so we can't determine anything, so it's going to be worst type. So here it's going to be best type, is relatively a best type, and also the male breast cancer and gastric cancer, colon cancer, pancreatic cancer, everything is associated, but everything is going to be good prognosis. So breast cancer, colon cancer, pancreatic cancer, and gastric cancer, so everything is going to be having a good prognosis here. Okay, so then coming to the why are we studying all this, we are going to determine the multimodality treatment here. Okay, multimodal treatment. Okay, what is the multimodal treatment here? Says that, see, we have chemotherapy, we have hormone therapy, we have radiotherapy, and we have the surgical therapy. And okay, so coming to the surgery, so surgery here, first we will discuss about the surgical part. The surgical part is the modified radical mastectomy. So modified radical mastectomy in Stewart surgery, we will taking a flap. So what are the things which we are going to remove here? Just the nipple, modified radical, right? We will be removing the nipple, areola, breast, tumor, pectoral fascia, and lymph node. Everything, every local structure will be removed, and main difference between the lymph node only. So lymph node 1, 2, 3, okay, and axillary lymph node. So this thing is involved in modified radical mastectomy. And then pectoralis major. So depending upon the retention or maybe the recession of the pectoralis major, only other types are either. When we remove the pectoralis major, it's going to be patty, okay, and then it's going to be retract, it's going to be arching clause, and it's going to be cut and resect, it's going to be scanlon. So scanlon is the oldest thing, and remove, cut and resect. Okay, you have to cut and resuture, cut and resuture is going to be resuture. So scanlon, patty is going to be for the removing, and retract is for the arching clause. Remember, arching clause is the first year PG. So first APG is going to be retract the arching clause here. So patty is for the parties, we are going to for the removal, and it's going to be cut and remove for the scanlon. So that is the thing here. Okay, so this is for the modified radical mastectomy. So the important thing here is what is the structures removed and what is the structure preserved. So the main thing the questions are going to be asked here is the lymph node status. So it's going to be 1, 2, 3 is going to be removed, axillary node is going to be removed, that's it, 1, 2, 3 AN. And then pectoralis fascia, tumor, breast, nipple, areola, and Stewart flap is going to be used in here. What are the structures preserved? So ABCD is going to be preserved. What is A? Axillary vessels, Bell's nerve, cephalic vein, thoracodorsal pedicle, and pectoralis major muscle. So these are the structures going to be preserved here. Okay, done. So then coming to the, we studied about the modified radical mastectomy, and now we see about the radical mastectomy. So what is radical mastectomy or Halsted mastectomy is that there is a ligament, the Halsted ligament is also called as the costoclavicular ligament, from the costo, the ribs to the clavicle. It's going to be a Halsted ligament or costoclavicular ligament. And then okay, I will just try to draw here a picture here. It's going to be axillary vein, okay, and then it's going to be that ligament, costoclavicular ligament, and here we have the Bell's nerve or nerve to serratus anterior, and we here have the thoracodorsal pedicle. Okay, so what is the thing here? So this is the angular vein. So it's going to be axillary vein above, angular vein below, and Bell's nerve in the costoclavicular ligament. Along with that, it's going to be the nerve to serratus anterior also, it's going to stay here, and thoracodorsal pedicle is going to be stay here. Okay, so here we are going to remove this thing. Okay, remove the whole thing, and minimum of 10 number of lymph nodes has to be removed in this section. Okay, but it is nowadays not done, so it will be not done. And what is the complications, other complications for mastectomy? Major mastectomy is that is seroma formation, because of which we will be using suction drain. Seroma formation, because of which we will be using a suction drain for the, and the treatment for the sudden fall of the suction drain. sudden fall of the suction drain, and it's going to be repeated aspiration and high tight banding has to be used. Okay, repeated aspiration and high tight banding has to be used, and most common nerve is going to be intercostal brachial nerve, and it's going to be injury to the structure, and it's going to be lymphedema. So lymphedema later is going to be lymphangiosarcoma. It's going to be Stewart-Trevis syndrome. And do you remember that lesser Trevis syndrome? Sorry, lesser Trevis sign. So lesser Trevis sign is seen in seborrheic keratitis. Okay, it's also seen in adenocarcinoma. So that can also be seen here. And the most common nerve is going to be the intercostal brachial nerve, and the seroma, because of which development of seroma will be there, because of which you will be using that suction drain for the 5 days. This duration is important, 5 days, and the drain has to be when there is a sudden fall of the suction drain, we have to do repeated aspiration of the area, and tight banding has to be given, and then axillary dissection is avoided. So what does it say means here? The axillary dissection has to be avoided when there is no lymph node is palpable. It's usually avoided. This is also a point here. So then okay, so when no lymph node is palpable, so it may be present underneath it. So how we are going to detect the lymph node and remove it by the sentinel node biopsy. So sentinel node biopsy is sentinel node biopsy. So sentinel node biopsy is by the isosulfur blue. So it's going to be radio labeled colloid. Isosulfan blue and radio labeled colloid is the thing we are going to use here. And in isosulfur blue, we have histopathological examination. It's going to be positive and it's going to be negative. HP can be positive and negative. So when it is positive, it's going to be axillary dissection, and when it's going to be negative, we can't take a node here, so we will be better going for axillary radiotherapy. Axillary dissection here and axillary radiotherapy here. Okay, so then okay, it's for the isosulfan blue. And what is for the radio labeled colloid itself? It's going to be highest radioactive lymph node. Okay. Highest radioactive lymph node via GM counter. Highest radioactive lymph node has to be treated with the radio labeled colloid via GM counter. Okay, so it's going to be HPE and isosulfan blue. So so we are proceeding to the what I have just said. Then contraindication is going to be when it is node positive, there is no need for sentinel biopsy, right? What are the contraindications? It's going to be node positive means there is no need for rather than lobular because there will be that neighboring calcification is also there, and then previous breast surgery also there is no need for this thing, and then in pregnancy radiotherapy has to be avoided if lymph node is negative. This is the we can expect in future. So what is the thing I'm just trying to say here is that okay, we discussed about the modified radical mastectomy. So this is the important point here. So 1, 2, 3 and lymph node, and pectoralis major chin clause, it's the first Neet Pg, and it's going to be retractor, and it's going to be Kachan resection is going for the scanlon, and it's going to be patties for the resection, and it's going to be halstead, it's going to be costoclavicular ligament, and it's going to be angular vein above, axillary vein above, angular vein below, and it's going to be Bell's nerve and nerve to ferris anterior, and costoclavicular is going to halstead ligament is also called as the halstead. And here we have the thoracodorsal pedicle we have, so it's nowadays it's not done. Seroma 5 days, sudden tight dressing, and intercostal brachial and individual lymphangiodema, lymphangiosarcoma, axillary dissection. It is avoided when no lymph node is palpable. So in that case, how we are going to proceed is with sentinel lymph node biopsy. For sentinel lymph node biopsy, we will be using isosulfan blue and radio labeled colloid for the high lymph node and via the GMCSF, and it's going to be treated with the HPE, and isosulfan blue is by HPE, axillary dissection and axillary radiotherapy. Okay, axillary dissection and axillary radiotherapy, contraindicated is going to be node positive, and LABC is going to be negative. So previous okay. So it's going to be previous breast surgery we don't need to do, and lymph node is positive, we don't need to do, and in case of pregnancy, and we don't need to give for the radio labeled section. and LABC, so other contraindication. Okay, so this is the thing. Okay, so then let me do the last few sections of the is that silicone breast implant. So silicone breast implant, so what is a silicone breast implant? Okay, so shit color. Ignore the color there. Okay. Okay, so silicone breast implant. So what is the silicone breast implant is going to be here. This is the implant, and here we have the capsule of the implant. If both rupture, means implant would go for blood. If both this and this is going to be rupture, this both section will go into the breast parenchyma. So because of which inflammation is going to be setting in. Okay, if it presents inflammatory breast, it presents as inflammatory breast. And then linguine sign is going to be there. The capsular rupture is going to be seen as an intracapsular rupture. Intracapsular. Okay, that is the reason we have the implant is going to be rupturing here. So it's going to be for the linguine sign. So it's going to be for the linguine sign of the MRI in MRI. So intracapsular blood cancer in USG is also called as the linguine sign. Okay, and then reconstruction of the breast surgery. So reconstruction, it's breast conservation surgery, or maybe the reconstructive surgery. So it's going to be for the tram flap and a tram free flap. Here it is the pedicle flap. Here we nothing but the, it is based upon the superficial epigastric artery, C. So tram free, so C. So here it's going to be from the inferior epigastric artery, EA, pedicle, I. So IEA, inferior epigastric artery. And then deltopectoral black is also based on this inferior epigastric artery only. So it's going to be inferior epigastric, and that is the most common. Silicone we cannot give radiotherapy. Okay, so that is the thing we have summed up for the breast carcinoma in just 20 minutes. Thank you.